Hi, I'm Ralph Brindis. I'm president of the American College of Cardiology, and I'm here today with Dr. Tracy Wang, who's the principal investigator of the TRANSLATE-ACS study. Now, this is an innovative study that is taken on by both the American College of Cardiology through the NCDR and the Duke Clinical Research Institute. A lot of our hospitals are beginning to hear about TRANSLATE. Tracy, can you tell us more about this important study?
Very happy to. TRANSLATE is an observational study of MI patients treated with PCI. And what we're interested in is looking at how patients are treated both in the hospital setting as well as in the outpatient care setting. In particular, because there have been several antiplatelet therapies that have become available or will become available soon. I think the key is to figure out what to do with these medications, how do we incorporate them into routine practice, and when we use them, what are the benefits, the risks, and even the costs of these therapies. So TRANSLATE will really help us understand many of these questions.
Well, these are very important issues for clinicians to understand more. What value would it be for hospitals and their cardiologists to actually participate in the study itself?
Well, to start, we're very excited about this study because it's going to give us a lot of information about the patients, as I said, both inside the hospital as well as when they leave the hospital. We'll get information such as readmission to the hospital, use of their medications after they leave the hospital, patients' knowledge about the therapies that they're using. So these are things that we would not normally know from, let's say, one of our great registry studies such as the cath-PCI. So for example, if you look at 30-day readmission rates, this is something that we're very focused on recently. It's become a publicly reported performance measure. Many hospitals are working to reduce the frequency of these patients coming back to the hospital after an MI. But a lot of these hospitals don't have the resources or the personnel to track down each patient after they leave the hospital. What TRANSLATE would do is provide a quarterly feedback report in real time saying, among the patients that have been enrolled in TRANSLATE, what happened to these patients. It'll detail things like 30-day readmission, both to the original hospital as well as to other hospitals, and maybe even provide insight to potential reasons for readmission, such as a patient not being compliant with their therapies. And then armed with this information, many of our hospitals can say, okay, well, are some of these events preventable? What are the targets for performance improvement? Are there any areas of unmet needs? And go forward from there. Another potential value to participating in TRANSLATE is that it provides access to platelet function testing. I think we're going to hear about that a lot at this particular meeting. And there's a lot of recent interest in looking at platelet testing results because we know they could be very variable for each patient. Hopefully this will help us guide therapies in the future. Because one of the goals of TRANSLATE is to look at how new technologies such as platelet function testing can influences treatment patterns, select sites within TRANSLATE will actually be provided with the ability to do platelet function testing, and they will test the patient and be able to get the results and see what the results are. So that would be another potential advantage to hospitals participating in TRANSLATE.
Well, I certainly can appreciate the value to the hospitals. I'm sure a lot of them would want to understand how easy it would be to participate or what the challenges involved, and particularly if you happen to be participating already in the cath-PCI registry, what would be involved to enroll in TRANSLATE?
Absolutely. I think this is a partnership between the American College of Cardiology and DCRI. So, and this study dovetails very, very nicely with cath-PCI. Cath-PCI already captures a lot of information about these MI patients and is already exposed to many of these patients. And what we've done is deliberately broadened the inclusion criteria because we want to look at what happens in routine practice. So participating sites would have to obtain consent from the patient to contact them after for us to be able to contact them after they leave the hospital. And then they would enter data about that indexed MI event into the database. Now again, for cath-PCI registry, it's very simple because a lot of this data is already entered, so they don't need to enter it again. The key thing about the study is there's no randomization. There's no assigned treatment. It's a very, very simple study. And one final note is that sites will actually be reimbursed for things like IRB fees as well as the per patient payment.
Sounds exciting and very, very reasonable for a hospital to participate. What about the patient after discharge? What happens then?
Well, I think that's another beauty of this study is that we don't necessarily have to burden the sites with going back and tracking these. That's exactly why we're doing this study. So all the follow-up after the patient leaves the hospital is actually done by the DCRI study team. So we will call the patients 4 times in the next year or so after they leave the hospital, and we'll track down things like were they readmitted to the hospital, what they were readmitted for, if there are any medical records that need to be chased down or bills or things like that to help us understand cost. The DCRI study team will do all of that. The beauty is after we get that information, we can actually feed that back to the original hospital and say, look, your patient did well after their MI, or if they came back to the hospital for any reason, we'll also be able to provide that feedback as well.
Seems like huge clinical value. If a hospital was interested in participating in Translate, how would they go about enrolling?
Well, there's a great website where this information is available. There's also an 800 number or an email address that should be on the screen. There are many ways to get in touch with us.
Well, thank you very much for being here.
It's my pleasure. Thank you.